Bom dia. Vamos dar início à defesa de tese de doutorado da nossa pós-graduanda, Fernanda Pipitone Rodrigues, orientada pelo professor do Jorge Mirena Haddad. Essa tese foi desenvolvida em conjunto na Universidade de Michigan, em Ann Arbor, e aqui na divisão de ginecologia, no setor de uroginecologia assoalho pélvico, do Hospital das Clínicas da Faculdade de Medicina da USP. Eu tenho grande prazer de fazer a abertura dessa sessão. Quero cumprimentar a Fernanda pelo trabalho que ela desenvolveu, todo esse período que ficou lá em Michigan, em Ann Arbor, um centro de excelência e que teve uma orientação importante lá do professor Delancey, a quem tive a oportunidade de conhecer lá nos Estados Unidos também. A tese vai ser toda apresentada em inglês, dentro do regulamento da pós-graduação da Faculdade de Medicina da USP, da Universidade de São Paulo, e a banca é composta pela professora Cássia Juliato. Professora Cássia, bom dia. Prazer tê-la conosco mais uma vez.
Bom dia, professor. Um prazer estar com vocês. Muito obrigada pelo convite, em meu nome, em nome da Universidade de Campinas.
Muito obrigado, Cássia. É um prazer, viu? Temos também a participação da professora Aparecida Maria Paceta, que é doutora e vice-coordenadora do setor de uroginecologia e assoalho pélvico da divisão de ginecologia da Faculdade de Medicina da USP. E o professor José Maria Soares Júnior, que é mestre, doutor e livre-docente, e é o chefe do Departamento de Obstetrícia e Ginecologia da Faculdade de Medicina da USP. Toda a titulação será desvelada depois pelo professor Jorge Haddad. Quero agradecer os suplentes, professor Pedro Maganhi, da Faculdade de Medicina de Ribeirão Preto, Departamento de Ginecologia e Obstetrícia, a doutora Silvia Carramão e a professora Isabel Sorpreso, que aceitaram a participação dessa defesa também como suplentes. E eu gostaria de fazer um agradecimento ao professor Delancey e ao Dr. Ashton Miller. I would like, Professor Delancey, to express my gratitude and to you, Professor Delancey, and the Dr. Ashton Miller for their valuable collaboration in carrying out this research.
Thank you.
I would like to take this opportunity to pay a tribute to my dear friend and chairman of the Obstetrics and Gynecology Department of the University of Michigan, Ann Arbor, Professor Tim Johnson, who passed away this year. It's very important to pay this tribute to Professor Tim Johnson. He's a good friend, a great professor, and Professor Johnson collaborated with us for many years. Eu gostaria agora de convidar, então, parabenizar mais uma vez, Fernanda. Eu tenho um compromisso, vai inaugurar o Centro Cirúrgico Ambulatorial, eu tenho que ir para lá, mas eu queria lhe cumprimentar, lhe parabenizar. Eu gostei muito da sua tese, da sua aula. Quero cumprimentar a sua família também, porque é importante a participação da família nesse toda essa trajetória sua, que é muito bonita.
Muito
Parabéns,
obrigada,
viu?
professor.
E parabéns, Jorge Haddad, por todo o trabalho que ele desenvolve no setor de uroginecologia e assoalho pélvico da nossa divisão. Me deixa muito orgulhoso, porque o Jorge tem uma produção muito grande e, além disso, ele tem divulgado o nosso serviço fora do Brasil, como presidente da IUGA, com todas as colaborações internacionais que ele tem. Parabéns, viu, Fernanda? E me desculpe, mas eu vou ter que sair.
Muito obrigada, professor.
Good morning, everyone. I would like to Good morning, everyone. I would like to sincerely thank Professor Baca for supporting a lot the Gynecology and Pelvic Floor Division, and the professor on this examining board for taking the time to be here today, and thank the audience and Fernanda's family as well. I'm going to introduce the professors at first. Professor Cássia Raquel Juliato, thanks Cássia for being here, head of the Department of Obstetrics and Gynecology at the School of Medical Science, Unicamp, University of Campinas, since 2023. She holds a habilitation degree from the University of São Paulo in Ribeirão Preto. She has been a full-time professor at the Department of Obstetrics and Gynecology at Unicamp since 2009. And currently an associate professor. She is a full professor in the graduate program CAPES Medicine 3, grade 7, and a level A productive scholar awarded for her significant contribution to medical research. And I would like to introduce my partner, Professor Aparecida Maria Paceta, PhD from the Faculdade de Medicina da Universidade de São Paulo. She is currently a PhD assistant at gynecology discipline of the Department of Obstetrics and Gynecology at the Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo, and co-chair of the Gynecology and Pelvic Floor Division at the same institution. And third one is Professor José Maria Soares, a very nice friend. He is the PhD and Sandwich Program from CAPES at Northwestern University Medical School at Department of Biochemistry and Molecular Biology in USA, and a full professorship at Gynecology Department at UniFesp. He is currently the head of Department of Obstetrics and Gynecology at Faculdade de Medicina da Universidade de São Paulo and this university, and associate professor in the same department. He's supervisor of the climateric section at the same hospital. He is a research productive fellow, 1C, awarded for his significant contribution to medical research as well. And I would also thank the alternate professors, Professor Isabel Cristina Espósito Surpreso, Professor Pedro Sérgio Magnani from Ribeirão Preto, and Professora Silvia da Silva Carramão from Santa Casa. And now, I would like to introduce Dr. James Ashton Miller and Professor John Delancey. They are doing fantastic work, and thank you for allowing Fernanda and our university to participate in this great study. Ashton Miller, who is the Albert Schultz Collegiate Research Professor Emeritus, Research Professor Emeritus of Mechanical Engineering, Biomechanical Engineering, School of Kinesiology, and Institute of Gerontology at the University of Michigan. Thanks so much, James. And Professor John Delancey, who is Norman F. Miller Professor of Gynecology, Professor of Obstetrics and Gynecology, and Professor of Urology at the University of Michigan. Professor Delancey, for me, it's a pleasure having you here. As former president of International Gynecologists Association, UGA, I think, is the best urogynecology society in the world. I consider you the most important urogynecologist in the world. And thank you, both of you, for taking the time to be here today. It's a great pleasure for us, and I would like to ask you for the comments at the end of the defense, if it's possible. Now I would like to invite the candidate Fernanda Pipitone Rodrigues to present her lecture. The title of the candidate study is Perineal Complex, Level 3, Assessment in Postpartum Women at High Risk of Pelvic Floor Injury on 3D Endovaginal Ultrasound. The candidate has 30 to 40 minutes to present the lecture about your study.
Thank you, Dr. Taji, for the kind introduction. The study was conducted at the University of Michigan under the mentorship of Drs. Delancey and Ashton Miller in collaboration with the University of São Paulo under the supervision of Dr. Jorge Haddad, my PhD advisor. And so to understand So to understand why we wanted to study injury in postpartum women, let's first do a brief background on childbirth trauma. So vaginal birth imposes a great stretch demand on the pelvic floor. So if we look here at this biomechanical model, where with the pelvic bones outlined in black, the fetal head is the blue sphere, and we take a closer look at this orange band here, which is the most medial muscle band of the pelvic floor, we can see that as the baby's head goes through the birth canal, this band has to undergo a substantial amount of stretch, which is 2 to 3 times its original length. And if you imagine that happening to your biceps, you'll quickly understand that that's not possible in any other part of the body. So this substantial demand sometimes surpasses the pelvic floor capacity, and that can lead to bony and or soft tissue injuries. And if these injuries don't heal properly, that can lead to early or late onset pelvic floor disorders. And in terms of disorders, pelvic organ prolapse is the disorder most markedly related to vaginal birth. We see here on this graph, on the y-axis, we have the incidence of prolapse along the years after first birth. In orange, cesarean section, light blue, spontaneous birth, and dark blue, instrumented delivery, meaning forceps or vacuum. And we can see that the incidence of prolapse is 3 to 5 times greater when you have a vaginal birth in comparison with the cesarean section. And so why does that happen? A common rationale in the literature is to say that vaginal birth causes levator avulsion, which is the detachment of the muscle from its pubic origin. That avulsion leads to enlarged hiatus, and that leads to the development of prolapse. So let's examine each of these steps. Does birth cause levator avulsion? This has been extensively documented and studied in the literature. So it can go to up to 50% with forceps delivery. If we look here on the right, on the left, this is an axial MRI scan, which is close to lithotomy position. On the patient's left, you can see this dark band of tissue, which is the levator muscle that reaches up to the bone. And on the patient's right, the muscle is not there. It has detached from the bone. So this is a unilateral avulsion. So yes, this step is true. Does an enlarged hiatus lead to prolapse? It is true that it can have a confounding effect, meaning that the prolapse itself can dilate the introitus, dilate the hiatus when it's present at the introitus, but it has recently been documented in longitudinal cohorts that an enlarged hiatus precedes the development of prolapse. So there's not only an association, but a causal link between the two variables. So women were followed after first birth. The ones who developed prolapse had a 20% larger hiatus and enrollment. And if they had a hiatus greater than 3.5, they were at a 9-fold risk of developing prolapse in comparison with the ones who had a hiatus smaller than 2.5. So again, this step is true. We also know that levator hiatus is indeed associated with prolapse when women with an avulsion have a higher chance of having prolapse in physical examination, of having symptoms of prolapse, and also of recurring if they get surgical treatment. And now, does levator avulsion cause hiatal enlargement? We can see here on this graph that almost half women with prolapse do not have a levator avulsion, so 45 of patients did not have avulsion. And also in logistic regressions, we can see that the presence of levator defect on MRI only explains about 15% of the variation in hiatus size. So it is true that levator avulsion can lead to an enlarged hiatus, but it does not tell us the whole picture. It's not the whole scenario. So our question is, what else can cause hiatal enlargement? What other injury remains latent after birth but impairs hiatal closure and appears later on as prolapse symptoms? In order to address that question, we have first to understand what keeps the hiatus closed. So what's a hiatal closure mechanism? The pelvic floor support is divided in 3 levels, as described by Dr. Delancey, and level 3 is the most distal level, and it is where lies the perineal complex, which is the system of structures that are responsible for hiatal closure. Let's take a closer look at that. So the perineal complex is composed of the perineal membrane, the perineal body, and the levator ani muscles. And here in this drawing, you can see it is a drawing of a cadaver with normal pelvic support. And when we compare it with this drawing here of a cadaver with an enlarged hiatus and prolapse, it is very clear that there are many differences and that the structures are not the same on both drawings. Levator ani muscles and the changes that it undergoes with delivery has been studied, but little is known about the perineal membrane and the perineal body, and in order to know how their impairment down the line leads to prolapse, we need to understand what changes occur with birth. And to study that, 3D endovaginal ultrasound is a great tool because it's non-invasive. It provides us with high-resolution images, and it gives us this 3D volume, which allows for multiplanar imaging assessment of all 3 orthogonal planes, coronal, sagittal, and axial, and it also allows us to tip the plane to whichever angle is suitable for the structures we're studying, which is especially helpful in the perineum since structures come in from different angles. So with that in mind, our aim was to determine postpartum sonographic appearance of level 3 perineal complex components, how level 3 defect patterns correlate with hiatal closure, and how vaginal birth with and without levator defect can influence them. Our first specific aim was to develop a method to quantify the sonographic appearance of the perineal complex on ultrasound. And to do that, we first identified the 3 structures on ultrasound, verified these findings on MRI, and described the normal anatomy. And from there, we developed a method to quantify these changes or defect patterns associated with perineal complex injury. Our second specific aim was to, using the method developed in aim 1, to identify and compare defect patterns in 3 groups: cesarean section, vaginal delivery with and without levator defect. And for that, we conducted 3 separate studies asking the questions. So in study A, does levator defect alter muscle fiber direction and perineal membrane angle? In study B, are level 3 defect patterns associated with mode of delivery? And study C, do level 3 defect patterns influence muscle fiber direction, perineal membrane, resting hiatus measurements, POPQ values, or obstetric values of variables? This was a secondary analysis of the POPI study, which is a study conducted at the University of Michigan. Women were recruited within 48 hours of delivery. They had to be above 18 years, have the ability to read English, absence of serious medical conditions, and delivery at gestational age greater than 32 weeks. 2 cohorts were recruited. First one was vaginal delivery with high risk for pelvic floor injury, so they had to have at least one of these criteria: forceps or vacuum delivery, active pushing longer than 150 minutes, newborn weight greater than 4,000 grams, episiotomy or sphincter laceration. And the control cohort were cesarean section women who could be in their first or second cesarean section without second stage of labor. And this was a convenient sample. So at 6 months, we had 3D endovaginal ultrasound images at rest, POPQ examination, pelvic floor strength measured by this instrumented speculum you see here at the bottom right, and a subset of women also underwent pelvic MRI. On ultrasound, these variables were measured: perineal membrane angle, pubicoccygis muscle fiber direction, also pubirectalis muscle fiber direction, perineal body location, and pubic symphysis axis. These angles were calculated with the pubic symphysis axis being the reference line. So in this schematic drawing here, here's a pubic bone, here's the ultrasound probe, and so this is the reference line. And for example, here's the pubirectalis muscle, this is the angle we measured, and here would be the pubicoccygis muscle and the angle we measured. We also assessed hiatus dimensions, so we measured genital hiatus AP diameter and area, levator hiatus AP diameter, low hiatus transverse diameter, which means the transverse diameter at the most dorsal point of the hiatus, which translate the distance between the two medial ends of the perineal membrane, and pubicoccygis muscle length. We also had clinical demographic variables, age, BMI, and ethnicity, purity, mode of delivery, newborn, weight, and head circumference, length of second stage, perineal laceration, POPQ values, vaginal closure force, which was measured by the instrumented speculum I mentioned, and the status of the levator ani muscle on 3D ultrasound. Our statistic analysis was conducted with SPSS and Python software. ANOVA and Bonferroni adjusted post hoc comparisons were conducted for these numeric variables, and chi-square test was conducted to see the association between level 3 defect patterns and these categorical variables. We also calculated inter and intra-rater reliability using intra-class coefficients. So our result in AIM-1, we initially had 129 women with 6 months scans. 3 of them had to be excluded due to imaging artifact that precluded the adequate visualization of the perineal complex region. So we, for this study, we had 126 women, 32 were cesarean section, 69 vaginal deliveries without levator defect, and 25 women who had a vaginal delivery and a levator defect. Groups were similar regarding BMI and age. They were different in terms of ethnicity, but all 3 groups had a preponderance of Caucasian women. Groups were also similar in terms of obstetric variables, with the exception of fetal head, baby head circumference, which was greater in the group with the levator avulsion. Bear in mind that all of these women were already high risk. This is probably why the groups are similar. And then the first step of our results was to verify each of the perineal complex structures on ultrasound, identify them on ultrasound, and verify the findings on MRI that was conducted in a small subset of women. And after that was done in detail and in all 3 orthogonal planes, we went on to assess the anatomy, normal anatomy on ultrasound, again done in all 3 planes and in detail. I have here one example of the axial plane. So we are going from top to bottom, from bladder neck to perineal body. As we start here, we're going So here are the pubic portion of the levator muscles. We're going down to the perineal complex region. I will show two slices to illustrate that. So here, so this is an axial view. Up in the front, the bones, back here, the anal canal. The probe is here inside the vaginal canal. Here's the urethra. You can see here the levator muscles. The medial portion is the pubic exiguus. Here's the pubic rectalis. And here's a part of the arcus tendineus levator ani. And as we scroll down, we get to the perineal complex level, and we see this drawing of tissues to the midline. This pattern of convergence of structures to the midline was what we observed over and over in women with normal anatomy. And so we decided to better study this pattern. And that's why, that's when we described this hourglass band pattern that I will show you in these scans. So here's the same axial scan, so close to lithotomy position. I have here the urethra, the probe inside the vagina, and the anal canal. In the middle here, you have the same scan for comparison and a schematic drawing of the same structures. If you take a closer look, here you'll see a band going across from one side of the pelvis to the other and connecting the two sides. This is what we call the transverse band. And you'll see that the convergence of tissues, the pubiperinealis, pubivanalis, and the external anal sphincter form this appearance of an hourglass. You can see here in blue, and that's the hourglass appearance. So the combination of these two features, the transverse band and the hourglass appearance, is what we called the hourglass band pattern, or in short, HP pattern. So we wanted to study this pattern, and to do that, we needed to quantify these changes in different women. So each of the features is scored separately. If they are present, it's a score 0. If they're absent, it's a score 2. If the image is clearly not normal, but it does not reach the threshold to be called abnormal, we classify them as intermediate, and that was score 1. So let's see an example. I'm showing here examples where both features have the same score, so both present, absent, or intermediate, but bear in mind they're scored separately, so they can be discordant. Here both are present. We're going down from the levators toward the perineal body, and in a minute we'll get to the level here. And then you see the two shapes, and we get down, further down, to the superficial muscles. Again, we'll be going from top to bottom again, and we'll show an example of intermediate. You can see that this image is different from the previous one, but not as abnormal as this one that you'll see right now. So this is a case of absent band and absent hourglass. So each feature receives a score, and the sum of the two scores gets is the total score, and the total score is then translated into the HP pattern status. So let's see, for example, if the patient has an intermediate hourglass, a present band, she then has a total score of 1, and that translates into a preserved HP pattern. On the other hand, if she has an absent hourglass, an intermediate band, she has a total score of 3, and that translates into an altered HB pattern. We performed inter and intra-rater reliability for each feature and for the total score. And our scoring system had high intra and inter-rater reliability. It's important to note that levator defect and altered HB pattern are different imaging abnormality, which is evident by their different locations in terms of craniocaudal axis. So this is the same subject. The top image is the levator the evidence of levator defect, and here she has a preserved HB pattern. A second example, she has an intact levator on both sides and an altered HB pattern. So to assess our second aim, we started with study A, which was to see if levator defect altered fiber direction. Here's each row is one structure: perineal membrane, pubic muscle, and pubirectalis muscle. Each column is a group. The tracings that you see in each of the rectangles are the actual tracings that were done in the scan, and the angles at the bottom left are the mean and standard deviations. Groups were similar for all three structures, and you can see there is substantial within group variability. And bear in mind that these are resting scans. For study B, we wanted to study the association between HB pattern and mode of delivery. You have here on the left, so each of the graphs are comparing cesarean section versus all vaginal delivery women. So here on the left, we have the hourglass appearance, which was significantly different between groups, and it was over 2 times more likely to be absent in women with a vaginal delivery. Transverse band was even more altered in, absent in vaginal delivery women, over 4 times more likely to be absent. And the total score as well was significantly more altered in vaginal delivery women. You can see here that almost half the cohort, a high-risk cohort, has an altered HB pattern. And cesarean section also had a few women with the altered score, about 16%. So, and we hypothesized that these women represent anatomical variation or differences in sonographic characteristics of the tissues. For instance, the band could be thinner, not allowing us to see it with this methodology. Now that we established that it is associated with vaginal delivery, we wanted to see if it was associated with levator defect. So the graphs that you see here only comprise vaginal delivery women. It's women without a defect versus women with a defect. The hourglass appearance was not significant between groups. The band, however, was twice as likely to be absent in women with a levator defect. And you can see down here that if a band is present, it is very likely that the muscles in these women are normal, because only 4% of women with a defect had a band present. And also it was very rare, only 4% of our cohort with a defect had a score of 0, which means that both features are present. Our last study was an exploratory analysis to see the association of HB pattern with all our other variables. For that, we used the vaginal delivery cohort with 94 women. We divided them by HB pattern status and levator status. So the first group, women had preserved HB and intact muscles. Second one, they had an altered HB and intact muscles. Third one, preserved HB and defect. in muscles. And the fourth group, both features were altered, were abnormal. In terms of hiatal dimensions on ultrasound, HB pattern alone did not influence the measurements. Women with elevator defect, as expected, had greater dimensions of hiatus, both AP diameter, area, and transverse diameter. In terms of POPQ values, again, HB alone did not affect pelvic support. Women with levator defect had greater GH both at rest and with Valsalva, lower point C and lower anterior wall. In terms of vaginal closure force, the volitional increase during a voluntary pelvic floor contraction did not differ across groups, although there was a considerable within group variability. And at rest, women with elevator injury had lower closure pressure, which shows us that it not only affects the ability to contract the muscle, but it can impair baseline muscle force and soft tissue closure force. In terms of obstetric variables, there was no difference in terms of long stage, second stage of labor. Levator defect did influence, was more often prevalent present in women with whose baby had a head circumference greater than 35.5 and a weight greater than 4,000 grams. HB patterns seem to be associated with perineal lacerations that would have to be further explored, but it seems logical since most of the perineal lacerations happen at the posterior fourchette, and that's where lies the perineal complex. So this is a novel level 3 imaging pattern. It proposes the understanding of perineal structures as a functional unit rather than individual components. An altered HB pattern is 2 to 4 times more prevalent in vaginal delivery women, and it is a distinct abnormality from levator defect. If it is proven to represent an injury, it expands our knowledge on birth-related injuries, since up until now we have studied levator defect and sphincter laceration, but they do not explain all the pelvic floor disorders that may follow vaginal birth. In terms of clinical significance, perineal complex disruption is potentially a repairable injury. It might be that we do not see a difference in pelvic support with altered HB because we are soon postpartum, 6 months, and these are resting images. So if it is a smaller hit than a levator defect, and it's still compensated at 6 months, but if longer down the road, these women present symptoms or worse support, we can use imaging to enhance the injury detection and then devise targeted surgical procedures. We also hypothesize that tears, obstetric tears involving deeper perineal tissues may disrupt the perineal complex, and that can potentially impair hiatal closure. This is supported by histological evidence of muscle fibers not only attaching or coming to the perineal body, but crossing the midline. This is recent anatomical work done by a Japanese group, and also by histological evidence of a thickened band of connective tissue between the posterior vaginal wall and the anal canal, which might represent the transverse band that we described. And that raises the question of repair adequacy in terms of obstetric laceration. We are often trained to repair the lacerations with the goal of controlling the bleeding and not always restoring the anatomy. If these structures retract below the mucosa and we do not reach laterally to get them and back to the midline, we're not restoring the perineal complex anatomy, and this might further down the road impair hiatal closure. In terms of strength, this was a high-risk vaginal delivery cohort, which enriched our sample of injuries while having a cesarean section control group. Our scoring system had a high intra and inter-rater reliability. We use ultrasound images, which enables us to transfer the findings into clinical practice and provides us with this multi-planar 3D reconstruction, which is especially well suited to analyze perineal structures that come in from all different angles. Our study has several limitations. It was a modest sample size. It was a secondary analysis. We didn't have a nulliparous control group. Follow-up relatively short of 6 months, and these images were only done at rest, which does not put the tissue under stress, and so we have still to further assess how they behave under load. In terms of future directions, we need a prospective longitudinal study with nulliparous as control group so we can assess the effect of pregnancy itself. Targeted biopsy studies to understand better which structures are altered. At the time this cohort was recruited, we did not have a validated questionnaire to assess for short-term perineal complex disruption symptoms, but a Swedish group has since published this Captain questionnaire that might help us elucidate those questions in future studies. And we also have to assess the long-term consequences. As an example, this is an ongoing study at the University of Michigan being conducted by Doctors Leon Chen and Peyton Schmidt. They are recruiting back the same POPU women, which are now 7 to 11 years out from their first birth, and they're doing the ultrasounds with a bag of saline distending the hiatus. And this is only preliminary, but it is the differences between the images are very clear. This is preserved HB and intact levator, altered HB and intact levator, and altered HB and levator defect. So more to come here. We have to write researchers conducting this study with the help of the whole group. In conclusion, the 3 perineal complex components could be reliably identified on 3D endovaginal ultrasound. Novel level 3, this is a novel level 3 imaging pattern, the HB pattern, and it is distinct from levator avulsion, and it could be, its abnormal appearance could be reliably scored. At rest, levator defect did not alter perineal membrane angle and muscle fiber direction. HB pattern was 3 to 4 times more likely to be altered in vaginal delivery women, and it was markedly associated with levator defect. At 6 months, an altered HB pattern alone did not influence pelvic support, hiatus measurements, and obstetric variables. And an altered HB pattern might be associated with perineal lacerations. Thank you very much. I couldn't end without, before thanking my people, my friends and family. It is not a figure of speech when I say I wouldn't be here without you. My team at Hospital das Clínicas. It is a pleasure to share the trenches with you. It takes a lot of resilience and a bit of curiosity, or a lot of that, to work in the Brazilian public health system. And Dr. Zielinski and Ashton Miller, and pelvic floor research group, my Michigan family. When I chose to go to Michigan, of course, I knew what bright and exceptional researchers and physicians you all were, but I had no way of knowing that you were all also such good people, and I'm very grateful for that. So thank you.
Fernanda, it was perfect, 35 minutes. Now we are going to start the oral examination, and each examiner will have 15 minutes for their questions, and the candidate will have 15 minutes to respond. I would like to invite the professors to participate in the oral examination, following the order in which they were introduced. Please, Professor Aparecida, Professor Zé Maria, and Professor Cássia, could you start it? And after that, I would like to ask for Professor Delancey and Dr. Ashton Miller for making some comments about that. I think it would be very important. Thank you. Cássia?
Can I start?
Yes, please.
Okay, thank you. Good morning. It's a pleasure to take part in this examination today. First, I would like to apologize for attending online rather than in person. George knows that I prefer to be physically present, but due to university issues, this is not possible. Second, my congratulations to Dr. Fernanda Pipitone Rodrigues. The Tese is very well written and scientifically solid. Fernanda, your work shows not only technical skill, but also a clear anatomic way of thinking about postpartum pelvic floor injury. I also want to acknowledge Professor George Haddad for the methodological rigor evident, George, in this project, and the intellectual influence of Professor Ashton Miller and Professor John Delancey, whose anatomical framework helped us to see pelvic support as an integrated system rather than a single structure. I think that what this dissertation does especially well is to focus on a region that is functionally important and often invisible. And we're talking about level 3 perineal complex. Fernanda, you do not treat level 3 as a passive perineal area, but a closure system, a combination of a perineal membrane, perineal body, and a continuous fascia that work together to guard the genital hiatus. This matters because for decades, the clinical narrative was centered on the levator N as a core lesion, while level 3 was often seen as a secondary or cosmetic or simple obstetric scarring rather than through structural damage. Your dissertation, Fernanda, challenges that hierarchy by demonstration. You propose a reproducible ultrasound signature named the HB pattern for a structure that has limited image language and therefore limited visibility in research design. In summary, this thesis open a new diagnostic frontier in pelvic floor imaging. By giving level 3 a measurable signature, it gives clinics a language, and once a structure becomes linguistically visible, it becomes clinical syncable. This is how a new thing to work. Your work advances the fights, not be repeating that we already measured by illuminate what we have now been measuring and perhaps what we should have measured all along. Congratulations again for the maturity of the science and the clarity of your contributions. I have some questions for you, Fernanda. I would like to start about the conceptual findings. And the first question, I think, George, could I ask and Fernanda answer in the same time, or would you prefer that I ask all the questions first?
Yeah, it's absolutely fine.
Okay, thank you. Fernanda, first of all, do you think childbirth-related pelvic floor injury should be reframed as a multi-site failure model, heading that elevator-centric lesions model?
Hi, Dr. Acacia, thank you for all your comments and again for being here with us. Yes, so if we think about childbirth injury and the pelvic, especially concerning the pelvic support, it is what the group and Dr. Lancy and Esther Miller call the multi-hit paradigm. So levator defect or levator avulsion seems to be a greater hit to the system, but all structures work together and they interact with one another to maintain the system working. And as in any system, if one structure fails, the other one might compensate. And it's just, and for the whole system to fail, it has either to be a big hit, or multiple structures have to fail at the same time, or other intervening factors down the line will, like aging, can also decompensate the system. So yes, I completely agree with you. I'd say it is it should be a system approach, like multiple structures are functioning at the same time and interacting with one another. I think the key point here is for us to understand how they interact with one another in order to maintain function. It's not, if we study structures in an isolated matter, for example, as you say, the levator and eye muscles, avulsion, no avulsion, dichotomize that injury, we did not get the whole picture and we won't understand childbirth injury to its full extent.
Thank you, Fernanda. And what do you think about when level 3 is disrupted, the autos loses protection even with preserved levator strength. Do you view hiatal enlargement mainly as a sequela of close failure rather than the initiation injury? What do you think about this? What begins first?
I'm sorry, could you repeat the last part? Hiatal failure as a consequence of?
Do you think this is what happens first? The hiatal enlargement or the close failure?
I believe that the failure of the hiatal closure mechanism is what when the system is stressed and the closure mechanism is not functioning to its full capacity, then the hiatus is enlarged. So I would say that the enlargement is a consequence of the disruption, not necessarily of the let's say the perineal, the HB pattern or the individual structures of the perineal complex, but a failure of the system. Yes, so I'd say the system fails, it cannot be compensated anymore, and then the hiatus is enlarged.
And you found HB abnormality, even some cesarean birth. How do you explain these finds?
Yes, this is an important point. Thank you for this question. We do hypothesize that they might represent some anatomical variation, but what could also happen is that these women, the sonographic characteristic of these tissues are a bit different. So scoring them in axial plane alone might not be enough to identify the structures. Towards the end of the project, we we were also able to identify the band on mid-sagittal plane. So that might be an alternative to enhance the scoring system in the future. So yes, I would say that this 16% of women with an altered HP pattern can represent anatomical variation and or sonographic differences in tissue characteristics.
Fernanda, I would like to ask you about the methods. You choose the 6-month postpart windows, and it was a strong design choice. What do you consider? Do you consider that 6 months is the ideal period to see these women? 6 months for partum. Do you think this is the ideal time to see these women?
I'd say 6 months is a good timing to scan for injury or to have a triage for injury. But if we're thinking about pelvic organ prolapse, the system hasn't been under load for long enough to give rise to those symptoms or worsen pelvic floor support. So if with longitudinal studies and long-term data, we are able to determine that this disruption of the complex down the road leads to development of prolapse or symptoms, then I would say that having them earlier, screening them earlier at 6 months would be the right data point or time point to screen for those injuries. I just think that we're one step before that. We first need to prove that the system will be decompensated down in a couple of decades.
And you choose high risk women pelvic floor birth. Do you think that you choose a low risk, the results will be the same?
Yes, I would think that the percentage of abnormalities would be much lower. We always talk about childbirth trauma and pelvic floor injury, but a substantial amount or a great amount of women in vaginal birth go well and we don't have any injuries. So a high-risk cohort was necessary to enrich our sample, and so we could be able to find those injuries and study them. But yes, if we had a low-risk cohort or a population-based cohort, I imagine we would find a much lower rate of abnormalities, as happens with levator defect.
Okay. And about the endovaginal ultrasound, you choose endovaginal ultrasound, but you evaluate the hiatal area. It's a central in your work. Would transperineal ultrasound be useful to complementary this information? What do you think about to use the transperineal ultrasound?
Yes, it's a great point. I think both of them have advantages and disadvantages. The endovaginal ultrasound has the advantage of giving us the ability to assess the urogenital hiatus and not only the levator hiatus, which is usually not possible with a transperineal, but it can alter the hiatus size. So the probe itself might make a small hiatus larger. So we approximate the normal ones from the abnormal ones. An abnormal hiatus wouldn't be altered by the probe, but a normal one might. So we have a smaller gap between those women. So I agree with you. That's a limitation of an endovaginal probe. And that would not be a problem with the transperineal. The problem would be to assess urogenital hiatus. That's why majority of literature with ultrasound, transperineal ultrasound reports levator hiatus, because that's what we can do with that kind of probe.
And I would like to ask about the MRI. You perform resonance in 6 women. How did you select this number? And do you think this, in your view, it was sufficient for the aims of your study?
Mhm. This was a convenience sample. It was the 6 women who, in the initial project, had both MRI and ultrasound. It is certainly a small sample. This is why we we state that we verify the findings. We cannot say use the word validation. Although having worked with these scans in perineal complex imaging, I do believe that ultrasound is a better imaging method to see those structures than ultrasound, since the probe is very close to the structures and close to the skin and close to the vaginal mucosa. And so I would say, yes, the sample is small. We cannot say it was validated with MRI, but I do not believe that's an issue, because, as I said, I believe ultrasound should be the gold standard for perineal complex, as it is much better, well suited for that part of the pelvic floor.
It's a low-cost technology. It's easier to done. And I would like to ask about the HB abnormality. What do you think? Do you think that HB abnormality precedes, come first, hiatal enlargement? What do you think? Come together, come first? What do you think about it?
We believe that the altered HB pattern represents a disruption to the hiatal closure system. So but it might represent a smaller, as I said, a smaller hit to the system that makes the hiatus, that keeps the hiatus closed. So if it is compensated by other parts of the system, then it will not translate into hiatal enlargement. If with the decades that follow with pelvic floor loading that daily life activities impose, if that injury gets decompensated, then it'll lead to a hiatal enlargement.
Fernanda, if you could follow these women in a longitudinal cohort, what do you expect that happens with HB abnormally? Do you expect that persists, progress, or normalize like a biological repair? What do you think it could happen if you could follow these women?
If I understand correctly, your question is if I think they can heal, if the HB pattern, if the abnormal women will improve the altered HB pattern, and then yes, that might be an option. I'd say that at 6 months, most of the postpartum healing has occurred, not everything, but there's still some amount of tissue healing up to 1 year or 18 months. But at 6 months, the majority of it has already happened. So, and also another issue is the intermediate cohort. Those might represent partial disruptions of the complex, or even women that did not heal adequately postpartum. So this is more of a guess, but I would say that they would not heal. They would not change their imaging pattern. They might not translate into symptoms if, as I said, the system doesn't get decompensated. But I wouldn't say that imaging pattern would go away.
Okay. And about elevator end defects, based on your results, elevator end defects did not change muscle fiber directions or perineal membrane angle in your cohort.
Correct.
And it was consistent with the literature. But do you think, do you find that bilateral defects occurs only in 9 of 126 women? Do you think that bilateral defects are necessary to produce these changes in the direction of the fibers, directions, or the angles of perineal membrane? What do you think about the bilateral or unilateral defects and these changes in the muscles?
I would say that the first issue with the fiber direction is that we're analyzing images at rest. So it might be that with Valsalva or even in upright position, we might have a different finding with the tissues under load. I'm not sure if a bilateral defect is what is needed to change the direction of structures, but it does signifies a greater impact on the pelvic floor, so that might correlate with a greater with architectural distortion to a greater extent. So that might be one of the findings. In terms of perineal membrane, that is very interesting because with levator defect, it gets sometimes really hard to analyze the scans. The anatomy is distorted, and even when it's not a complete avulsion, it is hard to identify the fibers. But even in those women, the perineal membrane is there, and it is fairly easy to identify the membrane. So they are not, at least at least the pubic portion, I'd say, or the anterior portion of the perineal membrane, the one closer to the pubic bones where the muscle detaches from. So I would say they're not impacted in the same way as the muscles. So to answer your question, I don't think it takes a bilateral avulsion to affect the membrane angle. It might be compromised in other parts of the system that would do that. But again, we need to assess the images.
Not at rest.
Training or upright, yes.
And finally, I believe that sandwich experience it's very helpful during the doctorate process. Could you briefly share your experience with us? I think this is an important part of your doctorate.
Yes, yes, this was an exceptional experience to me. I went to Michigan in 2019, July of 2019. I didn't have a specific project by then, so I went to work with Dr. Delancey and Dr. Ashton Miller in the pelvic floor research group, and I was involved in multiple projects, which was very good for my learning. I developed multiple skills. I started working with imaging, which I had not before. So I was in Ann Arbor for 2.5 years, and then I came back to Brazil. By then, we had already started this project. That's when I started my PhD here. And then this year, I went back to Ann Arbor for 4 months to finish this project, which was also invaluable. It's always the chance to be this close to Drs. Delancey and Ashton Miller, and the amount of knowledge I can gain from the group. I'm very, very grateful for this opportunity.
Did you spend 2.5 years? Is it?
Yes,
Oh,
the first
nice.
time. Mm-hmm.
Fernanda, congratulations for your work, for your doctorate. It was a fantastic thesis, and I appreciate to be part of your dissertation.
Thank you. Thank you very much.
Cassia, thank you for being here. Are you satisfied?
Yeah, completely.
Okay. Thank you so much for being here. And now, Professor Aparecida Maria Paceta, please.
Well, first of all, I would like to express my gratitude for my nomination to this examining board alongside friends I greatly admire. To evaluate the candidate who has conducted an impeccable study. This is a collaborative study carried out between the universities of Michigan and São Paulo, oriented by Professor Haddad, a world reference in the urogynecology world, and mentored by one of the greatest icons of urogynecology in the world. For me, the greatest, Professor Delancey, and also Professor Ashton Miller, globally recognized for high level of research in biomedical engineering. Regarding Fernanda, only praise Fernanda. She managed to accomplish her study with excellence, and certainly any one of us would dream of doing a work like you did. With the highest quality, having the best possible mentorship in urogynecology worldwide, like this. That's it, dot. A very well-written, easy to read, and which brings many scientific and practical contribution to the urogynecology. So, Fernanda, now you are here reaping the rewards of a beautiful job, probably with the admiration of the most of us, perhaps with envy of others. But the truth is that the path that you traveler to get here today is not and was not simple. And I recognize this effort. It involved sacrifices, living out your comfort zone, having courage, and developing resilience. I want to say that I really enjoyed your study, and I would have many questions about the results and the future application and development and future developments. But we have a limited time for questions and answers, and I will ask 3 or 4 main questions. Fernanda, is there an estimation of proportion of nulliparous women who naturally present outrage HB is about 9%? I can assume that the rate is the same of that you found in cesarean population?
We did not have a nulliparous group. We only had a cesarean section control. I would assume they would be similar. I cannot see a cesarean section without second stage of labor disrupting the perineal complex, but that has to be further confirmed and investigated.
Okay. In this context, do you see if we can believe that is about 9% the HB?
For the band, yes.
Yes.
Mm-hmm.
In this context, do you think it would be interesting to in the future or now recommend this type of assessment in conjunction with a routine obstetric ultrasound before birth to evaluate the HB pattern before and after delivery, if necessary. How we do nowadays with the fetal echocardiography? We recommend to perform it between 28 and the 32 weeks of pregnancy, the evaluation. Because in this case, probably we would recommend this kind of patient. Do you think we would recommend this kind of patient to don't have vaginal birth and go to cesarean?
I would say that screening for the HP pattern in pregnant women might help us further study the pattern and understand the effect of pregnancy hormones on those tissues. That being said, an altered pattern is a sign of disruption, well, hypothesized to be a sign of disruption of the complex. So I don't see it being predictive of birth injury. It might be a better use of the pattern to screen women after birth to understand what happened and if they need additional repair.
Yes, okay. But don't you think that it will be useful in any way in the future, previous the birth?
It could be. Yeah, something that we do need to enhance our prediction of women who will be injured in birth is the behavior of soft tissue in the birth canal. We do not have much information about that. So in conjunction maybe with biopsy studies and biomechanical, I'd say stress tests, we could associate that with the imaging pattern and from then on predict who will have an injury and who will not, hopefully.
And do you think when we are performing this surgery to correct the perineum complex, this kind of action with this knowing would be postponed or avoid the prolapse in the future?
That's our hope, yes.
Yeah.
If you reconnect structures to the midline, you, as best you can, restore the hiatal closure mechanism, and that hopefully can help decrease the chance of development of prolapse, or at least slower the rate of a prolapse that's already there, the rate of improvement.
And do you think the size, the measure of hiatus would be less than 4 or less than 3 centimeters in the correction, surgical correction?
The studies we have on that in terms of greater post-operative recurrence use either 3.5 or 4. So I don't have an exact number. If you want to use, yes, I would say 3.5 would be a good cutoff. 4 is 3.5 is more conservative rate. 4 is clearly altered, abnormal.
Okay. I consider that the women situation with the birth and everything, it's unfair. I have to say that. And consider that 15% of women will have problems, disruption and prolapse and everything of that. Today, with your current knowledge, would you still recommend vaginal delivery to your patient? Sorry for that question. But, if so, based on what?
Yes, I would still recommend a vaginal delivery. We have to remember that this is a high risk cohort, so we wouldn't have those high numbers in a population based study. And also, we have to remember, as much as we are biased, right? We see these women bothered and disturbed by their symptoms every day, but we cannot lose the whole picture in terms that cesarean section has its complications, and when it goes wrong, the risk is much higher in terms of bleeding and infection, and that then having a prolapse. I'm not saying that having a prolapse is nothing. It is. It can be substantially bothersome, but it cannot be compared to a risk of bleeding or infection or yes. So I understand. What I do think we can do better is understanding to which women we can offer an elective cesarean section, and to understand her priorities. Does she want to have one child? Does she want to have 3 or 4? Is she 40? Is she 20 years old? Is she an athlete? So I think all those questions should be considered when choosing the mode of delivery. So when I say that vaginal birth, yes, I would still encourage a vaginal birth. I'm talking about the general population, a woman, any woman in the streets. But we do need to do a better job counseling the patients in terms of the risks of pelvic floor disorders, and considering their individual characteristics when choosing the mode of delivery.
Part of my last question you just answered, but what do you think women should know about vaginal delivery that doctors and the researchers haven't yet had the courage to let them? Because I consider that the women is balancing between defending and denying the vaginal birth without information. And information is power. You just have a good decision when you have the right information.
Yes, I completely agree with you. In my experience, the postpartum women, they're most bothered or upset when they didn't know that was a possibility, that could happen, that they feel blindsided and betrayed. So yeah, I think we need to better inform the impact of vaginal birth on the pelvic floor, about possibility of prolapse, urinary incontinence, even anal sphincter lacerations. We inform more about that nowadays, but sometimes not enough. And that being said, it is not an easy job. It's not, you have to assess for blood pressure, diabetes, everything in a postnatal consult. So it's not, to add something else to that list, it's not trivial, but we can only get better at what we practice. So I do think we should introduce bit by bit those informations, and they can do not only make informed decisions, but they can they do not feel that their body failed when that happens. They come into clinic feeling betrayed and blindsided, and thinking that they did something wrong and that their body failed, and that's not even close to the truth. They just did a remarkable and incredible thing, which is giving birth to another human being, so they shouldn't feel this way a minute.
Thanks. Once again, congratulations, Fernanda. I'm sure that your family, in name of your father, your sister, and in memory of your mother, is deservedly very proud of you. Congratulations, George, Professor Delancey, Ashton Miller, Professor Baracá, my colleagues here present, and from the post-graduation service of Faculty of Medicine at the University of São Paulo. Thank you very much. It was very good to stay in this beautiful study, participate in this beautiful study. Thank you.
Thank you, Dr. Cida. Thank you very much for your kind words.
Okay, thanks for being here. Professor José Maria, please.
Good morning, everyone. Em português, is bom dia. Fernanda, I'm really pleased to participate on your board. Also, I would like to thank you, your advisor, Professor Jorge Haddad, and also your mentors, Professors Alston Miller and Professor Delancey. And also the graduate program of OB-GYN Department of Medical School for this invitation. It's a pleasure for me. First, I would like to do some comments on your thesis. But first, I would like to say about your presentation. Your presentation was clear, and your talk was so nice. Congratulations.
Thank you.
Your thesis, it is extremely strong, innovative thesis. It tackles an important and under-researched area of pelvic floor science with very rigorous methods, very adequate, very well done thesis. Congratulations also.
Thank you.
You show a deep understanding of the pelvic floor anatomy, excellent skills in the advanced image techniques, and the critical science thinking. It was demonstrated in your thesis. The work is new, well done, and explained with remarkable clarity. It not only meets the requirement for the PhD, but also makes a significant addition to science knowledge in this field. Congratulations also.
Thank you very much.
So now I would like to say some strengths of your thesis and the contribution of your thesis for the science. I believe that the biggest strength is move on the well-known. The elevator N, that I call LA, muscle injury. So you do more, you add more for the literature and the knowledge of this. By studying the perineal complex as the functional unit and define the new HB pattern, you advance the field. It gives us a new way to look at pelvic support and how it might be damaged during the delivery or the childbirth. I believe that's the questions of Professor Paceta about your opinion. Methods. You create the 8B pardon score system. I believe that is the major achievement. You carefully checked the ultrasound method against MRI, that's the gold standard for evaluation in the patients, proving their main tools is reliable. Create also a score that gives consistent results when the same person uses it multiple times or when different people use it. This is essential for others to adopt this new tool. Use it as smart strange to assess complex the 3D anatomy, double checking finds to avoid mistakes. It's important. It's double check. Congratulations also.
Thank you.
The clarity of your thesis. Your thesis was very well written, illustrated. You on clear diagrams and explained ultrasound images greatly help the reader understand the complex anatomy and the new 8B pattern, this course that you show us. The logic from the start to finish of your thesis is clear. In your thesis is really easy going. So congratulations. About your study group, use a group of high-risk postpartum women was a smart choice. This increased the chance of finding injuries, damage. Including a cesarean section group for comparison was crucial to see the specific effects of the vaginal delivery, the vaginal birth. Also, the statistical analysis that you perform in your thesis is really adequate. It is important. You didn't just compare the groups simply, but you explore how the LA injuries and the 8B pardon interact. Give a more detailed pictures of the types of the damage. So it is important that your statistic, how you did, how you present. The relevance of your thesis. You have success to connect the basic science and images to the clinical practice. It is that we want for the thesis in our university, to connect the basic to the clinical, and the discussion on how this could change the classification, repair the common theses during the birth is wonderful, insightful, and it shows a real-world potential of this work, your work. The ideas for future research are logical. Well, it is the best part of my comments, is the strengths. Right now, it's the limitations and some critical considerations. First, the sample size. The number of participants, 126, was enough to show the main effects. It's okay. But might have been too small for some details. Subgroups analysis. Also, your sample, the group was most Caucasian. So, the findings on how common these injuries are might not apply to all populations, such as African population. Another one, cause versus link. This is a good look at the single moment in a time. It's a transversal, 6 months after the birth. While it found a strong link between the vaginal birth and an altered HB pattern, it may not prove that the birth caused it. The altered pattern could be a result of the birth, or it could be a pre-existing anatomical difference of the patients. You correctly note this and suggest future studies starting before the pregnancy to answer this. And after, my question is how? Also, you show your scoring. I have some difficulty to understand the part of scoring that demonstrate, because it's not so easy. It's not so simple, yes or no categories. But it is the reality of the biological variation. And at the end of your presentation, you showed 3 images with this concern about this score and also the LA injury. So I would like some comments on this, okay? Now, the missing link into the function at 6 months. The key finding that the altered HB pattern alone did not link to worse clinical measurements at 6 months. Is both a strength, I believe it is honest reporting of the research, and a limitation. It means that immediately clinical impact is less clear, but it frames the HB pattern as potential hiding injury, whose effects might only show up years later. This find creates a new hypothesis for the future and also new research. Another comment is the probability effect. The student, you correctly note that the ultrasound probe itself might straight the area, potentially hiding the real difference between groups. This is a built-in limitation of the methods. Do you agree? I have more questions. So, now is for discussion. Given the high rates of the scores and how can they calculate, what specific anatomical or technician reasons do you think cause this variation? The last presentation, your slide that you put the 3 pictures, the difference. My question is, how would you improve this score to reduce this problem and these categories, this difference between the images, the HB scores, and the LH injuries? Your data suggests that the HB pattern is a separating injury from the LH avulsion. What is your main idea about the specific physical event during the birth, like overstretching or tearing, that cause the HB pattern to change. And the last one. The S analysis on how the probe sits in the vagina was interesting. Can you explain your idea that an altered HB pattern changes the probe's position? And what this might mean for the both clinical exams and future research? I will do some recommendations and conclusions. Fernanda, Pipitone, Rodrigues. You presented a doctor thesis of outstanding quality. Congratulations. Our work is original, methodologically sophisticated, and clinically relevant. You have successfully identified and described a new imaging pattern of the perineal complex. It's so difficult to do this. So congratulations. Develop a reliable tool to assess it and lay the foundation for new area for research into childbirth-related pelvic floor injury, which is really important. So I would like to say thank you, Professor Haddad, and you have your time to answer my questions.
Thank you. Thank you for your comments and important questions. Starting from the sample size issue, it is a modest sample size, so you have in total 126 women. And I agree, when we do the last study, the study C, when we divide women in 4 groups, that gives us a smaller sample size. That is, and it's an important issue, and that's why we call it an exploratory analysis. No final conclusions can be drawn from those comparison. For group comparisons, it was conducted so we could see where the signal lies, and then further conduct other investigations on those issues. So yes, thank you for this consideration. It is something to be attentive to. In terms of the population, yes, it was mainly Caucasian, 70 to 90% Caucasian women in the groups. That does not allow us to transfer to the general population. So yes, a similar study should be conducted with a more diverse population, so we can understand how ethnicity influence the sonographic characteristics of those tissues. Regarding your second point, again, that is very important. The design of our study does not allow us to infer causation. We cannot say that birth caused an altered HB pattern. That's why we are careful to say that it is highly associated with vaginal birth. So we would need to conduct a longitudinal study where we would have both an nulliparous group, so we can see the anatomy without any effect of either birth or hormonal pregnancy hormones, and then compare. So then to have these 3 cohorts: nulliparous, cesarean section, or cesarean section without second stage of labor, and then vaginal delivery. I think that launched those control groups, along with a longitudinal design, would give us would allow us to then conclude causation. In terms of the score, it is not, I understand by the pictures or the figures that we have, it is not easy to understand the difference between the scores, especially when we're talking about a 1 point difference, so between absent and intermediate, or between intermediate and absent. I think the issue here is that ultrasound is a dynamic tool, and with the 3D ultrasound, you're able to scroll back and forth, and your eyes account for different slices to do the final score. So the figures meant to represent with each of the scores, but we do have to assess the whole scan in different slices and neighboring slices to score each feature. It is not possible, or it's not, at least not advisable, to score them in one with a still image. In terms of the clinical implications, it might be that this injury, if it is proven to be an injury, that down the road it shows signs of either prolapse or other symptoms. That has yet to be determined. It could be that it's a hidden injury in terms, in the sense that it is not, up until now, it's not diagnosed postpartum. And also, the knowledge we have on childbirth injuries and the injuries that we were able to diagnose postpartum do not account for all the pelvic floor disorders that follow vaginal birth. So enhancing this detection early on, if not the HB pattern, something else has to be detected early on, so we can better understand why these women down the road present the symptoms and signs of pelvic floor dysfunctions. Yes, the endovaginal ultrasound probe is undoubtedly a confounding effect. It can, as I said, it is a worst, it has the most impact in normal hiatus, because then it dilates the normal hiatus a bit and it gets the dimension closer to the abnormal ones. On the other hand, it is a probe that helps us a lot with the urogenital hiatus and perineal complex visualization. A possible future project would be to compare the use of transperineal with endovaginal ultrasound to see how the images look next to one another. So that is an important point. In terms of improving the score, I would say that the most important part is to better understand what components of the perineal complex get injured, and what and how partial injuries occur, because here we're talking about injury, no injury, but in no part of the body is injury a dichotomous variable. You can injure different structures, you can injure it to different extents, you can combine different injuries that influence one another. So we need to further explore the intermediate category that might represent a heterogeneous population of women with smaller injuries to different components or suboptimal healing. So I think that would be the next step in terms of improving our score. And to answer the question, what phenomenon happens during birth that causes an altered HB pattern, I would say that certainly a perineal laceration is a great contributor to that. But we did find in that might be the main mechanism, but we did find an altered HB pattern in women who did not have a perineal laceration, or at least not a substantial perineal laceration. So the stretch component of the injury mechanism cannot be ruled out. And I think another issue here is the categories of perineal laceration. We say first, second, third, and fourth, but the second degree laceration is a very broad category, I would say. You can have a minor second degree with just a couple of fibers of the posterior fourchette, or you can have those complex second degrees that can be even challenging to repair. So another step would be to better categorize those perineal lacerations so we understand which structures they are compromising. In terms of the last additional finding that we reported, so everyone can understand, we had at the beginning of the study we had 2 reference lines. We had the pubic symphysis axis as a reference line and the probe as a reference line, and we did all measures against those 2 reference lines. But as the probe varies more, the pubic bone is a bony landmark, so it's a more reliable reference line. That's the one we used. But that being said, when we use the probe as a reference line and we divide the groups by levator defect, no levator defect, not accounting for HB pattern, there are no differences in fiber direction between groups. But when we divide women by HB pattern, altered or preserved, then we see a difference in fiber direction. So that might be because the altered HB pattern or the disruption of the perineal complex makes the probe lie differently on the perineum, and so it changes the axis a bit. That's why we put it as an additional finding. We would have to further investigate that and see that the fact that this difference has an image acquisition. And in terms of future research, I would say that standardizing the image acquisition method is crucial. May it be with the level on the probe, that's how it's usually done in Michigan, or with any other source tool that would allow you to say that all scans were done in the same way, that you didn't change the probe angle, because it's very easy to do, to change a probe angle. So that is definitely an important point to keep in mind. Thank you. I believe, did I answer all your questions?
Are you satisfied? Thank you. Thank you so much for being here, Professor José Maria. And now, Dr. James Ashton Miller, you were so important for this study. Thank you again for being here. Would you like to make any comments or question to Fernanda? And thank you for everything.
You're welcome. Felicitações, Fernanda. It's not so easy to do a PhD in a foreign country and in a foreign language. And you've not only done that, but to any students who are listening, who are thinking of doing a PhD, the hardest part of doing a PhD is to pick a topic that if you find the answer, it will make a real difference. And so many PhDs, including my own, were really interesting to do, but they didn't make any difference. So you have definitely made a difference with this one, because it'll lead to decades of research that will refine the findings. And most importantly, it's going to make a difference to millions of women through improved care in the future. It's been an absolute pleasure working with you, Fernanda. You're an exceptional human being, warm and caring, And like a tiger, when you get something between the bone between your teeth, you persevere and you keep at it until you solve whatever the problem was. So congratulations from me and the furry friends in Ann Arbor.
Thank you, James. Thank you so much.
Thank you so much again for being here, and thank you so much for your kind words. And at the end, Professor John Delancey, who is the mentor of this research. And again, I consider you the most important gynecologist in the world. And I am the former of International Gynecology Association, and I know a lot of urogynecologists around the world. And for me, you are the best one. And please, could you make some comments? And thank you again for being with us. I think you are muted.
My pleasure to be here. And I wanted to express my sincere thanks, not only to Fernanda for all of the remarkable work that she has done, only a small portion of which is actually in this thesis, but so much about trying to help us understand the impact of birth on women's lives, and to call attention to the fact that we need to do a better job of understanding the injuries, preventing the injuries, and having information for women to be able to make better decisions. I'm especially grateful to Professor Georgia and to the whole department in Sao Paulo for allowing Fernanda this time to be able to come and spend with us. A lot of the insights that have come in our research group have come because there is a bright, dedicated, hardworking, and insightful person who has spent time on a difficult problem. Doing research in areas that are well developed is often, the pathway is easy to see, it's easy to know what the results will be. It's just a matter of doing the work to do it. But when Fernanda got started, we didn't really know anything about what we would find, but had these ultrasounds and knew that there was probably something in there. But it's hard to, I think, for people in the audience to imagine the difficulties of looking at these black and white images to try and see what's going on. And Fernanda did a remarkable job of first understanding this complicated anatomy and then starting to notice the things that were different between the women with vaginal birth and women without vaginal birth. And then, as James said, had the persistence and the hard work to be able to do the research that's necessary to ask the question, is this real or isn't it real? Can other people get the same kinds of findings? And I was surprised at how good the inter-rater reliability is. And I think that's a testament to Fernanda's clarity with which she was able to see these problems. And then to do the work of saying, what questions do we need to ask once we have this finding? And I have the highest regard for her dedication and the depth of her understanding. As I said earlier, the thesis is only one small part of this, and the other work that she's done in terms of writing about pelvic floor and level 3 and how that relates to our understanding of OP, and especially the woman's perspective of what is it that we need to do to better educate women about these injuries and to strike the balance between not making women unduly scared and reassuring them that the vast majority of women deliver without any problems. But for the woman who is injured, that she would feel that she knew about that and that the approach of the obstetrical team was appropriate. And then that we will have better treatments in 10 years for the women who have had an injury. So Fernanda, thank you for your generosity in spending so much time with us and putting up with all the questions and the sideways motion of research when we try something and it doesn't work out, and we try something else and it doesn't work out. And your dedication to getting done and presenting this beautiful thesis. I'm grateful, and you have my admiration for a job very well done. Thank you all again.
Thank you very much. Thank you, Drs. Delancey and Miller. It's been a true privilege and honor.
Thank you, Professor. I absolutely agree with your comments, and it would be a great pleasure being part of the group for this period. Thank you so much for everything. And now, as an advisor, I won't ask any questions, for sure. I would just like to say something about you, about the candidate, about Fernanda. You presented a wonderful lecture. I told you yesterday, your lecture is so nice. Congratulations. And I would like to say that you are a very special person, dedicated, hardworking, and you never give up on your goals and dreams, like going to Michigan for two years and a half. It's not easy with Professor Delancey. You did a fantastic job. I'm very proud of you, and it's a pleasure to be your advisor. Continue your great journey, and always count on me. And I would like to congratulate your parents and your family, and feel free to say anything.
Thank you. Thank you. Thank you very much, Dr. Judges. This wouldn't be possible if you hadn't supported me from the beginning. And the postpartum clinic that we started here, it was all, again, because you were on my side and pitched my idea. So I'm very, very grateful for all the support that you gave me throughout this journey. And yeah.
It was a pleasure, and count on me anytime. And now I would like to ask the candidate, Fernanda, and the audience to leave the room for a little time. And YouTube will also be offline for a few minutes. And we will return after the message to listen to the reading of the minutes and conclusion of the defense. Thank you. Just a few minutes.
Meninos, o YouTube já saiu do ar? Oi? Com a técnica. Bom dia. Alguém do SAD, por favor?
Oi? Ah, fechou, parceiro. Mas pode parar a transmissão já?
Ah, tá. Pode tirar do ar o YouTube, tá bom? Obrigada.
Ok.
Obrigada.